Hey YouTube, Matt again. So what you can see here is we have a very angry barking dog due to an ingrown toenail. So you can see this is the right foot of the medial sulci. That means the inside part of the big toe. What we're about to do is freeze the toe, so we use some spray to help cool it or anesthetize it a little bit before we put the needle in. So the best way to block a hallux, or the one that I find the best, is to do a 2-point hallux block. So there's 4 main nerves. There's 2 on the top part of the toe and then 2 on the bottom. And what we do is by going in on each side, we can go through the top and hit the 2 nerves on the medial side or the left side, and then we can go on the other side and hit the 2 nerves on the right-hand side. So again, when you are putting a local anesthetic in, it's sometimes better to go slow rather than to rush it in, because when you throw a lot of tissue or a lot of fluid in, it moves the tissue quite a bit and can be quite painful for the patient. So again, we've done the medial side, now we've jumped to the lateral side. So here I'm hitting the top part, so that I'm hitting that dorsal nerve, and then you'll see that I'm slowly filling it, and you can see the tissue expanding it, and then we're going deeper, and then we're gonna hit the plantar nerves. Again, when you are using the medication, the lidocaine, you want it to surround the nerves so that the nerves become frozen. So what I'm doing is I'm using gauze to help to move that medication around to help anesthetize the nerves or make the nerves numb. So we're using some sterile gauze to help make sure that the area is numb. When it is numb, you shouldn't be able to feel any pain, and you can see that's what I'm trying to do. So it's a little bit of a sharp object, and we're making sure that that big toe is frozen. So again, what we're doing with the betadine, so what the drape was just to help kind of keep it sterile. So we're putting some betadine on there, and so it's more to just that drapes to keep it clean. You can see we've got the sterile gloves on, and we're using a tourniquet to help push the blood away. If you use it from the furthest part away, then push the blood forward, you keep draining all of the blood. And then what I'm doing is I'm using a sterile piece of gauze to clean up the toe. Just the less fluid that I have around, the more I can see, which makes it easier for me when I'm going in there and trying to lift the nail. So what you'll see is where that nail was, and then you can see here I'm elevating it. So I'm getting underneath the nail, and the nice part about this one, and it's pretty amazing, is you can see how deep that nail was in there. And kind of, I show this a little bit here, but you see that piece of toenail that was growing into the tissue. So you can see there's almost about like 2 millimeters of nail that was in there, 3, and then there's about 4 millimeters of space from the one end to the inside. So you can see that we were from there to there. That's that 4 millimeters I was talking about. So that's pretty amazing how deep that nail was and why that it was causing this patient so much pain. So what we want to try and do now is cut that piece offending nail out and then permanently prevent it from growing back. So this is what's called the partial nail avulsion with matrixectomy, and it's a permanent nail removal. So again, I'm just explaining this to the patient here, and I'm kind of showing how that side of the nail was so deep, and it actually almost looks like the nail grew from us just popping it forward. So this patient had ingrown toenails routinely, and I was saying, if this was cut straight across, you might have prevented it more and more. And I'm just kind of having that discussion with them and just kind of showing them and helping educate them on how that was done. So you can see here where we were going to go in, and we're going to go in to remove that offending piece of nail. And the reason why we didn't want to leave this nail there was because that tissue was so inflamed that once that nail dropped, it would just become an ingrown toenail again. So what we're trying to do is we're separating that nail from the nail bed, and then actually going deeper to the nail bed, to the nail matrix. The nail matrix is at the base, kind of where my fingers are there, where your nail starts growing, and then it attaches to the nail bed as it grows out. Here we're using some kind of like a nipper or a nail cutter, and we're going as deep as we can to make that straight line to cut the offending nail out. And then what I'm going to do is I'm going to switch to a blade, and here the blade's going to go in, and we're going to go in and we're going to remove this piece of nail. So again, we're kind of popping through, and you'll see where my blade almost appears to pop, and you'll see it kind of here and there. It's popped all the way through. So now that nail has become loose, and we've separated it from the nail bed, and it's lifted from the nail matrix. So I like to make sure that the cut that I make is nice and fine, and we've kind of gone all the way through, because you don't want to leave a piece of nail down there. It just makes it a lot harder for it to come out. If you've left a little piece, if you take it kind of one big chunk at a time, it makes the surgery a lot easier. So here we're just grabbing some forceps. We rotate towards the middle of the toe to get all that offending nail out. And you'll see here we've got it, and then I'll pull it out. So it's still attached to some tissue, and we'll kind of clean that up. But you can see at the base there, see how it's kind of wavy at the bottom? So that's attached to the nail, but at the bottom it's kind of wavy. That lets you know that you've got it from the nail matrix. So that means you've gotten the entire nail, because that's what you're looking for to make sure that this nail never comes back. If you leave a piece of nail, it doesn't matter how much chemical you put down there, the nail will come back, because you want to destroy that nail matrix completely. And you'll see here, what we're going to do is you want a completely bloodless field. So what we'll do is we'll dry it, and then we'll actually use phenol, and we'll use the Q-tips. And what the phenol does is it causes scar tissue at the base and destroys that nail matrix, so you'll never have that offending nail come back. So here you'll see I'm trying to make this area as completely bloodless as possible. So I'm using some gauze in my nail elevator just to make sure and dry it as much as I can, to really make sure that it's clean and dry. And then when we put the phenol on, we're just guaranteeing its success. So here it is, that's the phenol. So you want to do 3 times 1 minute applications with the phenol. So you can see I'm putting it in, I'm rotating towards the middle, towards the offending nail, and then we're killing not only the nail matrix, but the nail bed as well, and creating that scar tissue. And what this does is a 98% success rate, and that's proven by clinical studies, that this nail will never grow back. So again, we're going in, what we're doing is that 1 minute application of the phenol to make sure that we create enough scar tissue so this nail never grows back. So phenol is a chemical burn, creates a chemical burn that destroys the tissue. And we do the 3 times 1 minute application to make sure that we're completely burning that tissue and destroying it. So you can see how that tissue has now started to go white, and you can see how much of the burn it's already created. So what I'm doing is I'm prepping the second one for the 1 minute application to get rid of it even more. You don't want to put too much of the phenol on, because if you put too much on, then you'll create a chemical burn, destroying much more of the surrounding tissue. So what we're doing in this case is we want to make sure that there's enough that we're hitting all of the tissue, but there's not an excess amount that's going out onto surrounding tissue. Okay, so now that we've put the phenol on completely, we want to neutralize it with alcohol. So we've created enough tissue, but now we want to make sure all the phenol is gone. And then what we're doing is we've taken the tourniquet off, and whenever you take a tourniquet off, you're going to get that influx of blood, which you'll see here, because you've now helped, all those tissue has now become dilated, and the amount of trauma that we've created is now going to give you that blood flow. So what I like to do is leave a piece of gauze on there, and then put some forceps on just to put some pressure there, and then to get rid of some of that tissue. So as you can see there, we've now removed the piece of gauze. You can see the piece of nail that has been removed, and you can see the amount of space that will allow that skin to come over, so that when it heals, it shouldn't be there. So there you can see the nail is not going to be offended. What we do is we put some antibiotic cream to make sure that it's nice and clean, and that just helps to aid with healing. We like to use flamazine if the patient's not allergic to any sulfa drugs, just because it's best for chemical burns. Then we put on some sterile gauze. I used 2 in this case, just because there's a little bit of a wider toe, and then we use just the tube gauze to help keep that in place. We have that nice applicator, which allows us to put it on pretty easily. You can do it with just your fingers, but the tube gauze applicator makes it slightly more easy. And then we'll attach that. The patient will come back in a week, and then there's a lot more steps to healing this, but this is just the surgery process that we're showing today.